we'll start off with the sustained, the stabilized, and the toggle, and we'll go around the ilium, okay? For the PI, you probably want to move your patient closer to you, remember that, because you're going to be thrusting up towards the floor just beneath the shoulder of that patient. All right, everybody remember that? So, I'm going to use which hand? Superior hand for my PI. Inferior portion of the PSIS, I'm going to have a fencer stance pivoted to the inferior. My liner drive is going to be P to A and I to S just beneath the shoulder of the floor right there. If it's a PIIN, I'm going to be in the inferior medial portion of the PSIS. I'm going to be aiming right here at the lateral portion of the torso at the 12th rib. I'll pivot my stance to accommodate that. And if it's an IN, I'm going to stand here, and then I'm going to roll my patient over just a little bit, stabilize the patient, and thrust. If it's an EX, I'll come over, contact the lateral portion of the PSIS on the other side. Again, roll my patient over and thrust. And if it's a PIEX, I'm going to aim it again at the torso at the level of the 12th rib. Okay? If it's the stabilized, it's all the same mechanism. Instead, what I'll do is I'll just bring this hand here now, and I'm going to stabilize the opposite ilium. It's all the same as the one previous. And with the toggle, the only difference is I'm going to now roll in with a high arch, toggle recoil, set my drop lighter, and use a toggle recoil mechanism. On the stabilized and on the toggle, you don't roll the patient over for your INs and EXs. All right, that's sufficient? Okay, for your double PIs, find the PSISs here and here, and your liner drive is going to be P to A and again towards the shoulders. This way, if it's a double AS, you're just going to pivot to the superior, find the ischial tubes, set up again this way, and your liner drive is going to be P to A in that fashion, all with drops. Okay. I think that's all for the ilium drops, isn't it?
Yeah.
Okay, well, the single AS, we didn't do that. Single AS, you can do it sustained, stabilized, and toggle, and we'll do them in that order. So sustained can either be pivoted to the superior, or it can be squared stance, contact on the ischium. This is going to be just beneath the ischial spine, just a little inferior to it, and your liner drive is going to be P to A. If it's a toggle, or excuse me, stabilized, I'm going to use my second metacarpal phalangeal joint, and I'm going to stabilize here up on the PSIS, and my thrust is coming through my inferior hand this way. If it's a toggle, then I'm going to stand squared, and I'm going to use a high arch and inferior hand, excuse me, and toggle. So you guys don't need me to do this, you know.
Just keep going.
Okay. For posteriorly rotated sacrum, let's just say it's a P-L. You can use either hand, superior or inferior hand. You're going to come in, you're going to drive it, set up just medial to the PSIS and drive back P to A, medial to lateral. If it would be a PI-L, the only difference you're going to do now is you're going to torque it up the joint this way. If it's an inferior sacrum on the left, or a PI-L, and we ask you to do a notch contact, then what you're going to do is you're going to come down and find the natal cleft, just lateral to the natal cleft. You're going to use a pisiform contact. Your line of drive is going to be all pretty much I to S, and you're going to torque it towards the opposite shoulder. If it's an apex that has gone left, which would be the same as the PI-R, or an inferior sacrum on the right, the apex has come to the left. I'm going to bring this leg over here. The involved joint is on this side, so I'm going to bring the involved leg over the uninvolved leg. I'm going to come up and contact the sacral apex here. I'm going to have my line of drive is going to have some I to S because I got to go to that shoulder, so watch your forearm, make sure it's coming in with some I to S. Stabilizing and opening the joint on the left with this thrust. It's a scissor move, and the thrust primarily comes through this inferior hand and you're pushing it up there. But force does come through your superior hand as you're opening the joint on this side. And if you're going to do a coccyx, what you need to do is you need to find the apex of the coccyx. You're going to have your volar surface of your thumb flat down onto the patient. find the tailbone. Once you find the apex of the coccyx, you're going to pull this out like this. And the tissue is actually going to make the adjustment. You're going to put your pisiform right on the thumbnail, and your line of drive is going to be I to S. If it has gone lateral, so if it was an A-L in this case, I'm going to find the coccyx. I'm going to take my tissue pull with a little bit of lateral to medial, basically the same thrust this way. If you have a base posterior S2, S3, S4, you're going to stand with your epicentral notch slightly superior to your contact point. It's going to be over the spine. Once you find your contact point, you're going to set up right underneath that sacral tubercle. So if it's in base posterior, you're going to set up right underneath there. Set up this way. Pull the bone up this way, and don't lose contact, and then shove it S to I that way. That would be in S2. You do the same for S3, S4, base posterior. Okay? If you have an apex posterior, you're going to pivot to the superior, find the superior aspect of the third sacral tubercle, put your pisiform right on there, your line of drive, you're going to be pivoted in real tight to your patient. Your line of drive is just P to A and S to I with the drive.
Goes for what?
Apex posterior. I can't think of anything else. Is there any more?
Supine.
Again?
Supine.
Oh, supine, thank you. Have a patient turn over supine. You can do a PI standing on the same side or standing on the opposite side. If you find a PI on the same side, so if, let's say he has a PI on the right, don't get confused when you turn your patients over between rights and lefts. That happens all the time. So you want to find the ASIS. You want to put the hip joint of your chiropractic index finger on the ASIS on the side that you're going to be setting up on. So this would be a PI on the right. Then what you're going to do is slowly open your hand. So you're starting like this, and you're going to slowly open your thumb like this until you find the pubic bone. Once you find the pubic bone, you're going to put your chiropractic index finger or your index finger right in here. It's going to help guide you along the pubic bone. You're going to take a knife edge contact. You're going to thrust A to P and S to I towards the patient's opposite foot. This is all done with the drop. If you have a PI on the opposite side and you want to stand opposite, that's fine. What you're going to do is have the patient go like this, make a little triangle here, a little diamond, put his thumbs in his navel and put his fingers down on his pubic bone. Then what you're going to do is you're going to pivot to the superior, have the patient move his fingers over so that you know right where the pubic bone is. You're going to bring up the opposite foot, and your line of drive is going to be A to P and S to I. These are all done with drops. If you have an IN, what you're going to do with the IN is you're going to stabilize the ASIS here, okay? So I'm going to come in like this. I'm going to stabilize it this way. I'm going to bring this up, bring this over like this, lean over my patient, and thrust back. If I want to do an IN standing opposite, that's fine. You can bring this leg up. So he has an IN now on the left side. I'm going to stabilize this ASIS here, bring this foot up off the table, bring this over, and thrust across that way. The thrust comes down through the shaft of the leg. If it's an EX, I'm going to bring this leg up like this, contact the ASIS on this side, bring my patient over, and I'm going to shove it under this way for the EX mechanism. You can do that standing opposite as well. Bring this leg up like this and shove it under this way. Make sure you get over your patient so you can get that line of drive. Is that it? If you know that many, you're going to do well. If you know that many, you'll do well.
You did them all in 16 minutes.